Assalamu alaikum, everyone. So welcome to another interesting session for glaucoma. This is a new pattern that we started for last few conferences, and in this one I'll particularly show you why this session has been important in terms of improving the care for patients. Dr. Rashid, is it okay if I start? Yeah, okay, thank you. So my name is Umair Kidwai. I work in a couple of private care hospitals in Karachi, and these are my social media associations, and I would be grateful if you can follow me on them. So this is a case presentation. This is partially a repetition of what we did in Karachi conference, but we learned something out of this case last time, and then we applied that in this case, and I'm going to show you how that application has helped the patient. Oh. Forgive me for my manners, sorry. So we've got now chairs, co-chairs ready. Moderator has taken a leave for 5 minutes. He'll be back in a minute. Anyways, is it okay? Now start? Yeah. Prof. Damji, okay? Yeah. So this is a case presentation of no financial disclosures. 9-year-old girl, gradual reduced vision, previously seen her father, who was completely blind and we were unable to do anything, offer anything for him at that point. And unfortunately, her father's 2 sisters were completely blind as well. People who've attended Karachi ophthalmology, they have seen this case to a level, okay? And it's the continuation of the case. So please don't get bored that you've already seen it, but there's a continuation to it as well. So the pressure, unfortunately, was very high, 40 plus, both eyes. Right eye is unfortunately not very good sight, counting finger, and the left eye 612, fully cupped. No. Can you play it? No, there should be a video before that. No. This one, can you play this? Yeah. So this is the clinical video. You can see that this is when the child presented to me. We don't even know where the pupil is exactly. Polychoria, lots of iris atrophy. And when I did the gonioscopy, it was completely occluded, 360-degree iridocorneal attachment. So we tried conservative management first. Unfortunately, no success. Now the challenges here is that the patient's got 360-degree iridocorneal touch. Patient lives quite far, poor economic background, and not suitable for TRAB. Because my understanding with TRAB is you need an anterior chamber to create this passage. And if there is no anterior chamber, because iris is adhered with the cornea, then TRAB is very difficult. So my question here to all the experts here, if you can just quickly sum up, is anyone would like to comment on this at the moment? Chairs? Any options, any of these options? I would like to keep it close-ended at the moment, so I finish on time. So any options, any of the 3 options would you select?
I think in these cases, bleb-based surgeries, ab externo bleb-based surgeries with tube, pressure flow will both work.
Anyone from the front desk? Prof. Damji, Dr. Manaz, Aisha? Sorry? Yeah. Yeah, so tube or valve surgery, okay? So I opted for valve surgery because this is easily available. Plus, you know, we've got more literature in terms of using the valve for kids rather than the tubes, the more advanced tubes. We don't have much of a literature. I emphasized this last time as well, and I put a lot of MMC in these patients because I knew they're going to scar. Um, and the new thing that I started is not to wash the MMC after applying it, but still. Anyway, so this is the Ahmad glaucoma valve implantation surgery. Um, this was the easy bit, to be honest, but the cataract removal was a bit difficult because we don't have exact pupil. I've shown a detailed video of the cataract removal or lens removal in this particular case in a previous session. Um, I'll just go fast forward in this because I'm running out of time. So because there's no central space, we have to create central space by excising or incising the frail iris fragments. And they're really frail fragments. You can't do much about them either. Those cerclage and those techniques don't work on these type of iris. Anyway, so the lens removal was straightforward and the AGV was placed. Initially for a month, the pressure was very good, but then pressure started creeping up. And become uncontrollable with even topical drops after 3 months. So at this point, I decided to take the child back to the theater and did the bleb revision surgery. It was a good dissection at that point. I was able to dissect the conjunctiva as well as tenon separately and placed good amount of, and you can see a good flush of fluid coming out when you just poke the fibrous capsule over the plate. And then I removed this large, thick, chunky fibrous layer. There's always a very thin thing that occludes the cord as well in these cases, so it's better to remove them as well. And then after this, a good closure of conj and tenon. I'll just go forward. Again, so it just dragged it a bit further, and 6 months down the line, pressure starts creeping up again. And you know, on maximum topical therapy, the pressure was again above 30 in this patient. And then this is where I ended in Karachi Ophthalmology Conference, and I asked all of you at that point, and most of the people suggested that, you know, we could go for a second tube in this eye. So because the child has both AG valve in both eyes, so I went for a second tube in the good eye, but went for a blab reconstruction in the other eye. So this time I decided to go for a Paul glaucoma implant instead of, you can see the previous scleral patch there for the Ahmad glaucoma valve. This time I decided to go superior medially. Wasn't challenging at all, very easy insertion of Paul tubes. Sorry, Paul plate of the Paul tube. Again, a good MMC application. Forgive me for the quality of videos, but this is the best I had. So we place the ripcord first. You don't need to ligate Paul most of the time, so I have never ligated Paul. But good, but you need to insert the supramate or ripcord suture. And then what's the most difficult bit is to insert this large plate under the muscles. I found it more difficult than bowel, to be honest. And then fixed the plate, and afterwards entered into the anterior chamber behind the iris, and further typical closure afterwards. See, I've seen her yesterday. So what happened is I did the blab reconstruction second time in the right eye. the right eye, which is the dense amblyopic eye. And unfortunately, I ended up with a bit of complication as the wound didn't close nicely, and that's why the pressure was low, and I ended up resuturing the right eye. But the left eye, almost a month after follow-up, it's doing very well with 9 pressure. Any questions?
I have a question. Oh, sorry, it's very loud. So why do you think the ameglaucoma valve tube failed in the first instance?
Yeah, the thing is, the literature so far is more for the ameglaucoma valve than kids, and this is what the traditional practice is. I was reluctant in placing the tube because, if you look at the literature of kids having Paul tube, you don't find any, or you hardly find any. So that's what's stopping me, because I don't have enough literature to place the Paul tube in a child as a first choice.
In my understanding, the main reason for failure of the ameglaucoma valve in such cases is that it allows a lot of aqueous to come out in the first place, in the bleb. And that is the main reason why it fails. So it's actually a very good idea to even consider ligating ameglaucoma valve too, and then you perforate the tube so that little bit pressure control is possible. Post-operatively, you can control the pressure with perforations and with the oral acetazolamide, and let the bleb mature very slowly with very little aqueous. And once the bleb has matured a bit, then you can remove the ligature, or the ligature goes away if you do it with Vicryl. And this allows the bleb to mature with less inflammatory aqueous in it, and that increase the longevity of the bleb. So with Paul, what you did is you passed the ripcord through, and that allows less aqueous to come out. So that means, the longevity of the bleb over there would be far better than ameglaucoma.
Yeah, that's true. Yeah. Thank you. So you have a question, yeah?
Yes, the question is that would you use beta blocker very early post-operatively? So it's an excellent question, because beta blocker is an aqueous suppressant. And if you look at the role of beta blocker in aqueous suppressants and the bleb maturity, it's a very positive, and you will find that in patients where you have used aqueous suppressant, like especially beta blocker, you may not need medicines 8 weeks afterwards. And also, beta blocker increases the hydraulic conductivity of the bleb. आप moderate मेरा तो कोई नहीं
Sorry, Yusuf is supposed to do the moderation because I think he's going to come and join us. So our next case presenter is Dr. Menaz Naveed Shah, and from Karachi, Menaz.
So there is no free lunch at the glaucoma table. And don't we all, as glaucoma surgeons or individuals taking care of glaucoma patients, realize that? So this is a case that presented during the peak of COVID. This is a 30-year-old female who was referred in. She had recently had adenoviral keratoconjunctivitis, and that was the reason she had actually presented to an ophthalmologist. And at that follow-up, she had been on steroids, but it was discovered that her intraocular pressure was very high. They tried to control her intraocular pressure with maximum medical therapy, which included oral acetazolamide. Her best corrected visual acuity was 20/40 in the right eye, 21/50 in the left eye, and she was a little hyperopic with approximately 2.5 diopters of hyperopia in the right eye and +3 in the left eye. On her presenting examination, when she was referred in and when I first saw her, her cornea had stromal haze and discrete epithelial stains. Her intraocular pressure was 44 in the right eye and 46 in the left eye. And of course, now this is like the peak of COVID, and we're restricted in what we can do in terms of taking her to the operating room and getting her into clinic over and over again. Her fundus showed a cup to disc of 0.85 in the right eye and 0.9 in the left eye, with a fairly corrugated appearing retinal surface in both eyes. And on gonioscopy examination, there was complete closure with no deepening with compression in either eye. The angle was visible enough for this to be ascertained. The 2020 hood reports show us obviously the retinal nerve fiber layer being significantly compromised both in the right eye and the left eye, and also the representation that you see um, on the extreme right here for the visual fields between the 24-2 and the 10-2 for both the right and left eye, expecting to show us significant compromise. This is also really helpful in the hood reports. Dr. Zia had also mentioned those. Sometimes, you have a situation where you can't even do a visual field, but you can kind of estimate what's happening with that patient according to the hood representation. On biometry, this young lady had an axial length of 21.84 millimeters in the right eye and 21.78 millimeters in the left eye. Her pachymetry showed a corneal thickness of a fairly thick cornea of 625 in the right eye and 628 microns in the left eye. Her anterior chamber depth on the lens star was 2.16 millimeters in the right eye and shallower still with 2.11 millimeter in the left eye. I was concerned about her cornea, and so I did get a endothelial cell count, which showed 2,840 cells per in the right eye with a hexagonality of 64%. The left eye was not as well preserved with hexagonality of 27% and a cell density of 2143. So given the fact that her cornea was really thick and I was concerned about her cornea, I felt that this first intervention, I would go ahead and take her to the operating room. Her intraocular pressures, despite acetazolamide, were very high in the 40s. And so I decided to do a bilateral sequential trabeculectomy the same day with MMC 0.04% for 3.5 minutes. This was I tried to always do as wide a dissection as I possibly can. And then this MMC was irrigated as we routinely do in cases. Her intraocular pressure on postoperative day 1 was well controlled. She was a little hypotenuse, 6 millimeters in the right eye, 4 in the left eye. Visual acuity was a little bit better. She had good blebs, no cellular flare. The AC was formed. There were no choroidal effusions. As the days went by on postoperative day 4, her visual acuity was 20/50 in the right eye, vision was improving, 21/50 in the left eye, vision improved there too, but her intraocular pressure was now 2 in the right eye and 3 in the left eye. By the first week postoperatively, the vision dropped in both eyes. Now her vision was back down to 2100 from 20/50 in the right eye and 2200 from 21/50 in the left eye. Her intraocular pressure was a 4, but the AC was not shallow. By postoperative day 9, the vision was now 20/60, a little bit better in the right eye, same in the left eye. The eye was soft. There was a shallow AC with no touch of the cornea to the lens. Her intraocular pressure was fairly low at 2 millimeters of mercury in the right eye and 4 in the left eye. A month later, her vision was continuing to get better. The right pupil was beginning to appear slightly oval, but it did not appear like the iris was incarcerated in a sclerostomy. She had large blebs. The left eye had a larger bleb than the right eye. The intraocular pressure now was 12 in the right eye and 3 in the left eye. The AC was formed, no choroidals. And just when I was beginning to feel that things were beginning to settle down and a better seeing right eye has been preserved, 2 months postoperatively, we began to see that her vision was still preserved, but she came back in with iris to sclerostomy in the right eye. Earlier, the iris was not incarcerated in the sclerotomy to my view, but the pupil was round. The intraocular pressure now was 9, partially due to most likely the obstruction of the sclerostomy, and 3 in the left eye. So I continued to wait, and another 3 months passed by. Her vision continued to remain fairly steady, but now she comes back with 3+ cell in the left eye in diffuse PAS, unexplained. I did a whole workup on her, everything was negative. No phlebitis, no vitreous cell. The intraocular pressure now is 1 millimeter of mercury in the left eye. Treat her with topical steroids, cycloplegics, she manage her, and she stabilizes out. A year and a half postoperatively, she develops significant pigment deposition on the lens in both eyes. Her PAS are now present in the right eye and in the left eye. The crystalline lens develops 2+ NSC and posterior subcapsular change, and her vision in the right better seeing eye begins to drop a little bit. Her intraocular pressure is 9 in the right eye and 4 in the left eye. That's where it stayed in the left eye. The AC is shallower, and she began with a lens that was 3.99 millimeters that had now increased in thickness to 4.31 millimeters in the right eye, and from 3.98 to 4.32 millimeters in the left eye. The AC depth was now shallower at 1.93 millimeters in the right eye and 1.91 millimeters in the left, 1.60 millimeters in the left eye. And you can see that from the post-operative comparison, the AC depth was now decreasing. So I made a decision to proceed with lens extraction, hoping that she would have better vision. She's also a school teacher, and she also was waiting to get a little bit more stabilized. She wanted to have a second child. So I knew this was a high-risk case, and 1 week post-op phaco in the right eye. The phaco was uncomplicated. The iris was occluding the sclerostomy. The intraocular pressure began to rise in the right eye, 23 millimeters of mercury. I tried to pull it down with an argon laser, could not do that at the laser, so decided to manipulate it surgically and also use that opportunity to revive the bleb a little bit. So I managed to get the iris down, but the intraocular pressure continued to remain elevated, and I put her on a fixed combination of timolol and dorzolamide, and the intraocular pressure came to 16. A week post-operatively, her vision in the right eye was, the vision of the left eye was decreased. On and off, I still saw cells, treated with topical steroids, significant PAS as preoperatively, and the bleb remained diffusely well-functioning. 5 months post-operative to the right eye, the vision is really good, but the intraocular pressure is now elevated again. And there are increased cells, and there's significant patient discomfort with prostaglandin analogs. She's on brimonidine and COSOP, and the pressure gets all the way up to 36, and that's a better seeing eye. So my options were right eye. Should I redo the trabeculectomy, use an adjacent new site for a new trab, or do an AGV in this eye? That's often sometimes, where you have so many choices, and each choice comes with its own set of pros and cons. So what would your next move be? Would you do any one of these 3 procedures, or would you do a different procedure?
Which morning?
Dr.
So I was looking at your biometric printouts. So I had to calculate, because you only presented with AD readings, not the ACD readings.
I'm sorry, I can't hear you.
I was looking at the biometry presentations.
Yes.
And it showed, I think it was a LensStar printout, and it showed aqueous depth AD.
Yes.
It did not show ACD, which is the...
Sorry, that was the AC depth. That's not the C is missing there.
Yeah, so C means that you add cornea to it.
Yes.
So even with cornea added, so I just did manually, it was around 2.7, 2.6 millimeter is shallow AC. But more importantly, the white to white in that eye was 11.2. So even if the eye is not classified as a microphthalmos based on axial length or on ACD, the white to white eye makes it a relative anterior microphthalmia. Mm-hmm. So these patients, they can have ciliary effusions. So, and this is why I think, this is why the cataract surgery is causing problems, because post-cataract surgery, when you get a ciliary effusion and inflammation, you tend to get hypotony. Mm-hmm. Hypotony alone does not lead to complications. You need added element of inflammation. So if steroids are withdrawn early, or if steroids are not adequate, then all of this starts to happen. Mm-hmm. And I think I will be very afraid to do anything in this case, because I know anything I do, it'll get worse. I don't know, you'll be very brave to do anything.
So what I ended up doing is I thought that if I put in a tube, this is going to be a very difficult situation with the cornea and corneal decompensation that you might have. She's only 30. So I did do a retrabeculectomy for that eye. And what I ended up doing is that I opened up the conjunctiva, and I actually found a really friable appearing scleral flap. And I opened up only the central area of the flap all the way into the anterior chamber, and did not open up the edges of the flap. So they were still adherent. And this was how the patient was doing back in August. She had a reasonably functioning bleb, and God's good grace, I mean, she's now, we're in December, so the post-operative day 1 was at the absolute end of July. She still seems to be doing okay. Now, I always, Dr. Merkidwai has been very helpful to me. He's also had a look at this case, and we just continue to monitor. But my question always is, what am I going to do next for her if her pressure begins to go up again? And that's really the question that I have of you. And I think partly you've kind of answered that question in your comment. So that's really it. Thank you.
Thank you very much. Very nice presentation.
Thank you. So we will take the question and answers in the end. Now I will ask Professor Karim Damji to present his case.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. I think these are all very challenging cases, so I'll add to the challenge. So what I'd like to do is, I hope by the end of this, for patients who have had a tube or a drainage device of some sort, if they develop an erosion, that you're comfortable describing the mechanisms and also recognize atypical infection as part of that spectrum. So the 74-year-old patient that Dr. Meher and I have been sharing with primary open-angle glaucoma that underwent uncomplicated phaco and then had trabeculectomy in the left eye and had aggressive healing and lost some vision, quite a lot of visual field. So that's the poorer eye. The right eye, in view of the poor results with the trab, had an AGV placed and did quite well for about 3 or 4 years. However, the patient had a history of diabetes, of dry eyes, preservative reactions, needed some serum tears, preservative-free drops, etc. And pressure was reasonably controlled, but then presented on September 6th with very intense pain. Now, she had had a partial erosion some weeks before that, or maybe even a full erosion, I think, but at the same time, she was not willing to go to surgery at that point. But on September 6th, when she presented, this was the examination, okay? So the pressure in the right eye was around 11, and she had eroded, right through the conjunctiva. I'll show you the photo in a moment. But she had this cuff of white material around the tube entry site, a moderate cellular reaction, fine keratitic precipitates, and a little bit of white stranding from the tube to the temporal angle. The lens was clear, no vitreous cells, some optic nerve damage of a moderate stage in the right eye, but still good visual potential. So this is the appearance of the erosion, a little bit of an extended area with quite a bit of inflammation. And if you can just see inside, there's a whitish cuff there. I don't have a better picture at the moment. So anyway, a question for you: what are the common causes of tube erosion? So for those of you that are residents, I think it's important to think systematically in terms of mechanical factors, whether it's the height of the plate or the location, rubbing of the eyes and so on, thin tissue, or sometimes very scarred tissue, dry eyes from multiple etiologies or immune dysfunction. You could have rheumatoid or some other problem locally, chronic use of steroids, which can tip the balance, and you can have collagenolytic activity, infection. And then in one study, the risk factors were described as African ancestry, diabetes, multiple medications with preservatives, multiple procedures, including laser procedures, etc. So in this particular case, we had the erosion that we thought was from dry eye, but then also superimposed infection. Cultures were taken which did not show anything. We started some antibiotics. The patient started to improve, and we counseled the patient to remove the device, but she was not keen, so she wanted a patch, and she went to surgery for the patch graft, which the results after surgery looked pretty good in terms of the patch graft and the closure. In fact, the little bit of area of whitening is beginning to improve. The chamber is fairly quiet, and the pressure is good. Vision is also good. And it started to grow staphylococcal aureus with the sensitivity profile shown there. Other cultures were negative, and we had specifically done stains and cultures for mycobacteria as well. So just in general, when you have endophthalmitis after valve surgery, it's typically bugs like Haemophilus influenza, Streptococcus species. It's typically delayed as opposed to early, and you have a much higher incidence in children. And common risk factor in most of the studies is erosion of the conjunctiva. So the patient came back 7 weeks later. The vision was now hand motions, and the pressure was almost zero. The tube seemed much longer in the anterior chamber. So obviously, either the device has moved or the eye is shrinking. Something, odd is going on. If you look here, the device is actually migrating anteriorly. And I think you can probably see from this Seidel test that over the plate, there is actually a nice brisk leak. So we counseled the patient and said, look, this is a problem because you normally don't get device migration this late. and the device needs to be removed. There seems to be some evidence of infection, etc. When we removed the device, the tissue paper thin conjunctiva, the device was actually loose. All the sutures had dissolved around it, and we could just lift it out. Normally you have to cut the capsule or the fibrovascular cores, and it was quite difficult to close the tissue, but we managed to close that, and that's the post-op appearance. Interestingly, we did 4 cultures, but the tenons and the actual device itself started growing mycobacteria. Okay, so this is not tuberculosis. This mycobacteria other than tuberculosis, and I'll show you the sensitivity profile. But we consulted infectious disease and started using some fortified vanco and amikacin, along with moxifloxacin, and then a bunch of oral agents that the infectious disease folks recommended. And the patient, had a little bit of a rise in pressure. We put her on COSOPT, and she was controlled reasonably well, and actually was doing fairly well. And then afterwards, after about a week, it wasn't too bad, but there started to be a little more anterior chamber reaction. And this is the sensitivity profile. Now, really, the organism is sensitive to amikacin, and I think to linezolid, but very few things. So it's quite resistant. 2 weeks post-device, the patient was taking all this oral and drops and starting to do reasonably well. But afterwards, just within 2.5 weeks, she had stopped using the oral antibiotics because of gastrointestinal upset. And I think you can make out there are mutton fat keratitic precipitates here, and there is an anterior chamber reaction. The external tissues looked okay. And so the patient actually was developing early what we thought endophthalmitis. So here are some more KPs. You can see some fibrin in the vitreous now. So we counseled the patient to undergo intravitreal linezolid along with amikacin, because those are the only things that we could inject safely that the bug was sensitive to. And post-intravitreal injection, she's done much better, and things are starting to clear up. There's a little bit of an epithelial defect here, but the chamber is stable, and she's doing all right. So we'll have to see how this turns out. I had one other case of this when I was in Canada, which turned out to be Mycobacterium chelonae, and this was a patient who had trauma and a tube placed and was doing all right for a while, but then started to develop this whitish material and inflammation and almost a necrosis of some areas of the external tissue, corneal dry eye, etc. So typically, these are ubiquitous organisms and a cluster of different types of organism, and it requires a high index of suspicion because it has an indolent course, maybe quite refractory to treatment. And the risk factors are if the patient's had multiple interventions, trauma, steroids, or some foreign bodies. A foreign body needs to be removed often if it's there. Contact lens use, or immunocompromised patients. And our patient had a variety of predispositions with the dry eye, the diabetes, the device there, some erosion, etc. Often the infection is actually as a keratitis, especially after laser refractive surgery. But it can involve the periocular tissues or intraocular tissues less commonly. And typically it's Mycobacterium chelonae. So culture is important to speciate and to do the sensitivity profile. Often you want to try and discontinue steroids for as long as you can because it's counteractive, just like when you're treating tuberculosis. And if you have an implant, it's 6 more times likely to lose vision and go into the eye and have a problem. And in fact, there's one case report of a dual infection with streptococcus and atypical mycobacteria, where the boy, actually a young boy, had some erosion, retraction of tissue, had some repair done, with amniotic membrane, patch graft, and then unfortunately still ended up losing vision with endophthalmitis. This was the appearance in the literature of the retracted necrotic tissue, and you can see some erosion over the plate in addition to the tube area. So I think the key point I want to hit home is that, look, please think of infection also as a possibility when you have patients with erosion. And if you see white material around the tube or even externally in the area of the plate or the device, you can actually see it may be mycobacteria, and then you need to do the cultures and think about removing the device and that's a summary of the risk factors. But I think these cases are complex and they need assistance often from other ophthalmology colleagues, but in particular infectious disease. Okay, thank you very much. Do we want to take a question or something, or you can do it later?
Yeah, we can. We have time in the end.
You remove the tube when it was anteriorly moving forward, isn't it? So why did you decide to do that rather than refixating posteriorly?
I felt at that point there was infection that was present based on, the fact that the device was slipping. There was an anterior chamber reaction, little bit more keratitic precipitates. So I wasn't comfortable just doing a revision because I thought that there is some kind of infection here and it's going to get worse if we just refixate it and leave the device in. So that's why we removed it. More of a judgment call, but the patient was not doing well. The eye looked quite sick. Did you have any other questions? Or?
So it's a very nice presentation, Professor Damji. I still couldn't understand why did it happen in the first place?
Right. So I think that the patient had some very serious dry eye. She did not go to the OR straight away when the erosion was initially noted. Dr. Mayer may recall, but I think there was a period of a month, 2 months where we kept counseling her, but she did not want to go to the OR. Maybe the organism was introduced at that point because it's in the soil, it's in the environment, it's not like natural flora. And then after that, it was quite a toxic situation, right? So Dr. Mayer, did you want to comment? You knew the patient before I did.
Actually, one of the problems that she was having was that she had uncontrolled diabetes, number one, and she had severe dry eyes because she was suffering from arthritis. And we have been trying her dry eyes with all the preservative-free and artificial tears, even autologous serum drops, So we feel that that can be one reason that conjunctiva gets thin and the tube gets exposed. But she is saying that, we have got experience of 2-3 patients that we have recently, in the last 1 year, removed the AGVs, and they all had exposed plates or tubes, and we have taken back and sutured them. And they have, everything, sutures have broken down again within a couple of weeks' time. So the literature tells us that you cover it with, stored sclera or pericardium, but it has not worked in these patients. And one of the patients had a retinal detachment surgery, and other patient was uncontrolled diabetes. So I think they have some kind of immunological reactions, and that's the reason they cannot do well with the AGV, and unfortunately we had to remove them.
Yes, I think so. I think the bug had gotten in, and then with the combination of rheumatoid, dry eyes, diabetes, whatever, she just did not get better.
Okay. Thank you.
Thank you.
Thank you. So now I will call Professor Syed Imtiaz Ali. He will present his case.
I think we need to move from the surgical aspect of glaucoma to a little bit of medical problem. And my case is not that complicated, but it just asks a question that can glaucoma coexist with a neurological disorder, or was it really glaucoma? So I saw this lady referred from Gilgit by a junior doctor to Amanatai Hospital in Islamabad. You can see that intraocular pressure was 25 in the right eye and 30 in the left eye. She was hand movements in the left eye and 618 in the right eye. CDR, 0.4 and 0.9, and she was referred for and it says cup disc. She was referred for asked to take an opinion from somebody in Islamabad. She ended up with me. She was a 35-year-old lady and very hefty. She was overweight, and I suspected this was my paper. You can see she was put on let-up by the doctor. The notable thing was that her CCT was 480. She was already on let-up and controlled 16 in the right, and the same, I noted that the right disc was 0.5 and the other was 0.7. So in routine, I ordered a OCT for glaucoma because it was available there straight away. This was the OCT. You can see this is the one eye, the right eye, and that is the left eye. Quite informative and quite suggesting of glaucoma. You can see the CCT is 480. I have marked it there, 480. So everything was going in favor of glaucoma. But looking at the disc, I was not convinced myself, and I was asking myself, is this cupping or is it pallor? I'm very keen to distinguish a pallor from a cup disc. So I ordered a visual field, and this was one field, and you can see the other eye. So the diagnosis was very obvious and evident that this was a typical bitemporal hemianopia, right? Then why should she get a bitemporal hemianopia? And if it was a glaucomatous field, it did not respect the horizontal meridian. So this is my writing, and then my suspicion was getting closer. So I ordered this was the information for the radiologist: glaucoma, optic disc pallor, visual field show bitemporal hemianopia. Advise MRI brain with contrast to rule out SOL in the brain. And this is the report that we get. You can see there's a big pituitary adenoma sitting there. And this was the report and conclusion. Either it is an aneurysm or pituitary adenoma or a cranium pharyngioma which was pressing. So my request to the juniors is that every cup disc is not glaucoma, and everything here was going in favor of glaucoma. The CCT, the intraocular pressure coming down with Zolatan, and then she had a successful removal, and she did not come back after that. So another similar case, this is my writing. This patient presented with 20/30, 20/60 vision, and complaint of history was diplopia. Intraocular pressure 15 in one eye, 13 in one eye, CD ratio is 0.5 in both eyes. And I just gave her a vasodilator. I was not convinced what was going on, and her complaints were very peculiar. They were not fitting into anything. And so what I did was refer to neurologist. If you see that yellow marking, I referred her to the neurologist. And he did what I should have done. He did an MRI of the orbit and brain, and he came up with this diagnosis: pituitary macular adenoma, supracellular meningioma. Then she went to Shifa International Hospital, diagnosis pituitary adenoma, and she had a transsphenoidal removal of the pituitary adenoma. And this was the impression: large lobulated extraaxial enhancing cellular supracellular predominantly solid mass, including left cavernous sinus encasing the left internal carotid, and differential include pituitary adenoma, supracellular meningioma, and chordoma. And this was, she had this removed for endoscopic transsphenoidal excision of the pituitary adenoma, and this was the MRI of that patient. That is the MRI. So this is a bit of medical aspect of the glaucoma. Always be aware that the two diagnoses can exist together, or maybe whenever you label it as glaucoma, try to differentiate between a pallor of the disc and a cup disc. They are two different things. Thank you.
Thank you, sir. Any questions? Okay.
So I just a comment, I think those are excellent cases. I think the other teaching point is that the visual acuity was down, the central acuity in both those cases. So just for the residents, in glaucoma, of course, you don't see that until later on. Now, routinely, I was going to ask you, do you check color vision as well? Or do you do that only?
Oh, forgot to mention the color vision. In the first case, the color vision was depressed. I did not do it in the second case. Did it with the Ishihara.
Right, because the red-green is typically not reduced in glaucoma
Yes.
early on, and then whereas in these compressive lesions, it seems to be quite depressed.
That's
And then of course afferent defect that is significant, and the age profile, and there's a lot of red flags, right, altogether that suggest atypical. In addition to the disc, yeah. So just those are a few points I wanted to make. Thank you.
Thank you.
So just question from Professor Karim Damji. So how do you check these color vision on which test do you do? Is this Ishihara plates or any other?
Right. If the acuity is good enough, I think the Ishihara is fine. Otherwise, you can use a cap, bottle cap, a red, and look at the desaturation between the eyes. Or if you move it across the hemifield, you'll often get a different color perception across the hemifield.
Yeah, see, I just want to comment because I'm going to show this Miller case, and unfortunately, Ishihara did not show us the red and green color defect, and we did not have a sophisticated 100 hue test or any other things, And then I'm going to show you the slides and RNFL analysis of these cases, and patient came out with a diagnosis of pituitary tumor. But I think your point, I take it that when we are not sure that these patients should have a detailed color vision examination. Yeah, very important.
Thank you, sir.
Can I add something? Do we have time?
Yeah.
So one thing I would like to mention that traditionally RAPD is mentioned as a diagnosis for glaucoma, but technically speaking, RAPD is very uncommon in glaucoma, and it's a very advanced asymmetrical glaucoma. RAPD is more of a neurological, and Professor Imtiaz has mentioned about the pallor. The pallor is classical for the neurological diseases, but we were having a very common things are commonly right, so that's spot on. But we were having a very interesting discussion the other day, and the optic nerve head cupping is divided into prelaminar and laminar portions. And in elderly patients, they may not show cupping, they may just show pallor due to glaucoma. So in elderly patients, if you're getting pallor, then it's not necessarily a neurological disease. It can also be a glaucoma, which you typically call it a sloping slant. So this was an excellent presentation, and to keep mind open for both diseases occurring at the same time and mimicking each other. Pallor can happen in glaucoma and vice versa. And cupping can happen, prelaminar cupping can happen in neurological diseases.
Okay, thank you, sir. So next presenter is Professor Nadeem Hafiz, but is he here or someone? Yeah, okay. So he is going to present on behalf of Professor Nadeem Hafiz.
Good afternoon. I am Dr. Imran. I have the honor and privilege to represent Professor Nadeem Hafiz, but he is unfortunately not available due to some family engagements. After the very beautiful presentations, I would like to show a presentation which will draw your attention to another aspect of glaucoma in children with systemic diseases. This is a case of a child, 8 years of age. The child is resident of Rawalpindi, and he presented with right painful eye for 3 days and nausea for 2 days. And on general physical examination, a child with moon face and stunted growth, age-matched growth, and vitals were unremarkable, mild peripheral pitting edema. And this is the feature habitus of the patient. You can see that there is moon face and stunted age-matched growth. The child is a patient of nephrotic syndrome, taking systemic steroids for 4 years. On ophthalmic examination, the unaided visual acuity in the right eye was 6/60 and 6/9 in the left eye. Pupil right marcus gun is positive, extraocular movements are full, and nexa orbits are unremarkable. Ophthalmic examination slit lamp biomicroscopy shows right corneal edema, and circumciliary congestion, bilateral deep anterior chambers, and bilateral asymmetric posterior subcapsular cataracts. On fundus examination, the CD ratio in the right eye is 0.8 and in the left eye is 0.3, and there is a neuroretinal rim notching positive in the right eye. Gonioscopy shows bilateral open angles, and on applanation tonometry, Goldman applanation tonometry, the pressure is 42 in the right eye and 20 in the left eye. So this is a clear case of steroid responder. Drug history, as I have already told you, the patient is taking oral steroids for the management of nephrotic syndrome by pediatric nephrologist since last 6 years for nephrotic syndrome. And topical medications, he was taking these medications before being referred to us at glaucoma clinic of Jinnah Hospital. The patient was taking 2% carbonic anhydrase inhibitors and timolol combination, latanoprost and brimonidine, and systemic mannitol and glycerin were contraindicated because of the renal condition of the patient. Management of the patient was, we planned a combined procedure for the right eye because the pressure was 42 and there was posterior subcapsular cataract and the vision was 6/60 in the right eye. Irrigation aspiration with Alcon multipiece intraocular lens was done, and trabeculectomy with mitomycin C was done in a single session. So first of all, we went for cataract surgery with irrigation aspiration and multipiece Alcon IOL into the capsular bag. Okay, next please, थोड़ा सा आगे ले जाएं इसको, trabeculectomy part पे आ जाएं. So this was just irrigation, a simple irrigation aspiration, and the lens, multipiece lens was put into the capsular bag successfully. Then थोड़ा सा और आगे ले जाएं, 30 seconds और आगे. Okay, the multipiece IOL is being implanted into the capsular bag. Then we proceeded to the trabeculectomy of the patient with it at a different site from the cataract incision. 30 seconds और आगे ले जाएं, 1 minute आगे ले जाएं. We closed the main incision for cataract surgery with 10-O-proline and prepared a new site for trabeculectomy with mitomycin C. Okay, these are the steps of trabeculectomy we can well understand. Trabeculectomy was done successfully. Next slide. So there is nothing to, here lies the discussion. What was the fate subsequently? Intraocular pressure was controlled immediately after the surgery. Post-op, thick pupillary membrane was formed in the right eye, and this was very resistant to manage even with steroids. He was already taking oral steroids for nephrotic syndrome. We gave all possible routes of steroids, but this membrane was very resistant. And the patient developed sudden IOP rise in the left eye 2 weeks after the surgery of the right eye. Trab was done only in the left eye, and there was minimal inflammation was noted in the left eye. So here lies the debate. These are the 4 questions that arise. The 2 eyes of the same patient managed, but the questions are, should we do both procedures simultaneously in this situation? Should the site of dissection of the 2 procedures be the same or different? Or if done separately, what should be the gap between the 2 procedures? And which procedure out of the 2 should be done first? So these are the questions open to this August House for any inputs. Thank you.
Okay. So anyone want to comment?
Just a comment.
Last slide, sir.
Yeah, first of all, I'm a bit confused why the patient had such asymmetric glaucoma if the mechanism was steroid. So that's one question.
Yes.
Could there have been another mechanism also involved, even though we like to, keep it simple and think about only one mechanism? And, when the pressure is that high, then I myself tend to prefer just a glaucoma procedure to stabilize things and then go back for the cataract later, especially in a child because it can become very complicated.
Yes.
So yeah, that's what we were discussing, that we would have gone for trabeculectomy first, followed by cataract surgery. But maybe this patient was a case of nephrotic syndrome, and multiple general anesthesia would be a problem for that patient.
This was one of the reasons, sir. This was one of the reasons to give a single anesthesia because it was a high risk anesthesia.
So how bad was the cataract? How bad was the cataract?
It was posterior subcapsular grade +2 cataract in the right eye.
Was it significant to cause amblyopia in this patient?
Probably not.
So in that case, so it's a well-known fact that when we do cataract surgery and trabeculectomy together, or within 9 months of each other, trab is likely to fail. So if the posterior subcapsular opacity in this case was unlikely to cause amblyopia, then the best, I agree with Professor Meher, the best decision would be to stick with trab. And once the trab has settled down, then we can look at the cataract at a later date, but again with the risk of trab failure. The other question was,
It is single site or two sides?
The last slide questions.
yeah, so it's always best to separate sites. There is no evidence. If you look at the World Glaucoma Congress consensus statement, there is no clear evidence. The literature is split on this, but common sense prevails. So if you have done a bleb superiorly, you don't want to upset it. So best to go temporally in that case. And also, this case was a nephrotic syndrome. And nephrotic syndromes are classically associated with microphthalmos. And those patients, when you do trab or cataract, you can get very high spikes of pressures due to ciliary body irritation, ciliary body swelling, inflammation, and aqueous misdirection. So it's very important to look at the biometry readings in such patients too.
Thank you,
Yeah, I
sir.
just want to make a small comment. Although I realize that you guys put a tenonylon in the corneal entry wound for the cataract, but we use mitomycin C for the trabeculectomy, and we are always concerned it's seepage inside the eye. So we will prefer to do the trabeculectomy first, and then mostly at the 12 o'clock position, and then you wash it out, whatever the case may be, and later on from the temporal side, you can carry on with the your cataract surgery.
Yeah, so, but I would prefer single site because if you are doing two separate sides, it takes more time and you have to apply additional sutures to the corneal wound. So, anyway.
Also, it depends how you feel, because I have seen it when I am doing two separate sites, my success rate is better, although what Rashid is saying, the literature is divided, but I've tried to do it from the single site and I feel that my bleb fails, very earlier. So that's the reason I've chosen to go separate ways, and survives for the longer time.
Thank you.
The more important thing in this thing is that it's your personal choice and experience whether you go to different sites or the same site, but I think the common sense is two separate sites. However, the more important thing is that after cataract surgery, you need to put corneal suture in these patients. Any case of hypotony or low pressure due to micro leaks, and that's it.
Yes, sir.
Yes. Thank you.
Sorry?
It's always advisable to put sutures in pediatric patients. Is he's 8 years, so I think one should put suture. And it's better you would have included the photograph in an undilated pupil, so we could have assessed the visual significance of the cataract, because this cataract seems like more inferior on the inferior side. So it seems that the area surrounding the cataract is free of cataract. So it might not be visually significant. And as sir mentioned, if I would have gone for this surgery, I go for trabeculectomy, and then I go for cataract extraction in such patients.
Right.
And I prefer to go for two different sites, because studies have shown that going for different sites mean it becomes different procedures. One procedure and the other it has got high success rate than doing it through a same port.
Thank you.
Okay.
One practical point is that trap first is, as Professor Mar said, it's very important. And when you have the cataract first, you lose the integrity of the anterior chamber actually. So you have a softer eyeball, and you will have a very difficulty in even outlining your superficial scleral flap. So doing the trap first actually makes it easier to make the flap, to have a superficial dissection of your sclera, and you have more control over the eyeball as compared to if you have lose your eyeball anterior chamber integrity when you have a separate incision already formed. Either it's a 2.5 or 2.8 millimeter, you still put on a stitch on it, but you have lost the control of the anterior chamber still. Even you can put air into the anterior chamber, as you I think you put air into the anterior chamber. That may actually help retard the seepage of mitomycin into the anterior chamber, yes, maybe. But I would like to ask Professor Mar his experience that in cases in which we inject the mitomycin subtenon and we apply Mirocell soaked mitomycin under the tenon, is there any difference between the seepage?
No, there's none. And in fact,
so which one is more safer actually, I want to ask you.
Actually, both are the same procedure. And if you look at the IOP control, the one of my resident is looking at these cases for last several years, because now I used to put sponges, now we changed to the subtenon. And we know this has not been published, but we were asking about the results, and the unpublished says that as the IOP control is concerned, it's the same. But coming back to the point of doing the combined surgery can be pretty tricky, because see, what happens is that if your capsulorhexis is slightly larger and your anterior chamber goes shallow, which can go after trap, the central part of your lens, it can come out of the bag, and you will have difficulty. You have to take the patient back and put it in the bag. So when I'm doing it, I leave actually a lot of viscoelastic substance, and I don't wash it out after the cataract surgery. And I constrict the pupil before I even move on to do my trabeculectomy.
And also, one of the very important things in whether you're doing a combined procedure is a last resort. It's not in modern medicine. Whether you're doing a combined procedure or whether you do phaco after the trab, your phaco settings, they need to be low pressure and low fluidics, because as the fluidics increase, the intra-bleb pressure increases, and that causes the stimulation of mechanoreceptors. And that mechanoreceptor stimulation leads to laying down of the new ECM, which leads to trap failure.
Thank you. So our next presenter is Professor
Yusuf.
Banerjee.
See, I just have a question related to the MMC. I wanted to ask, there are some studies in rabbits where it shows that MMC can actually seep through when you get ciliary body shut down, and there's a little bit of or hyposecretion. In children particularly, because the sclera is thinner in circumstances where they've had glaucoma for some time, especially early on, are you ever worried when injecting MMC as you're preparing to do the trabeculectomy that might be a factor?
Professor.
Sorry, Manad, are you asking if you do the same thing in the children? The problem is if it seeps, how do we prove that it's not seeping inside it? The only thing is that if you do the specular macroscopy, look at the corneal endothelium at the later stage, which we haven't done it. We do not have those facilities. But otherwise, if you're looking at the cornea and corneal clearness, it is not affected by the, even we putting sponges, we're putting back. And by the way, when you're injecting the MMC, we have injected 10 millimeters away from the limbus. Now, the one question was raised by the Rashid was, what is happening to these patients about their superior rectus muscle? Do they have ptosis or anything? I've never seen ptosis.
But that really begs a really important question, because while we may be injecting very far back, and I'm not talking about now the MMC seeping into the anterior chamber, because obviously, so I'm talking about, because it's really far back, it's not going to seep into the anterior chamber. I'm actually talking about some of that MMC staying behind, gradually seeping through the sclera to the ciliary body. That is a concern that we don't have enough data on it, but it's something that bothers me as I think about it.
But what we do is, once you inject it, we open the conjunctiva and we immediately wash it out, and we just make sure that we squeeze it out from the thin ounce capsule and it's not left behind. Another thing is, that if you leave it MMC behind, your conjunctiva can slough out, because I can tell you, one of my residents unfortunately left the sponge behind, and patient comes back after 2 weeks, you can see the conjunctiva sloughing out. And what was popping out through was the piece of a sponge, So we have to take the patient and take it out. So clinically, we can say that it's not causing any problem.
Just to add a quick comment that Sharon Friedman at Duke University, so my philosophy was the same, that look, it could penetrate, cause a cyclitis or some unknown thing, or maybe even scleral melt or something. But she has been using mitomycin in kids with good results, so she seems quite comfortable with it. I can't remember the dose and so on. So I guess clinically it's been okay, and a lot of people use it. But nobody's studied it systematically with some imaging or other testing to see, like, is there some effect on the uveal tissue, Yeah, pre and post, right.
And one study has shown that, when we wash it out, because it might go into the nasolacrimal duct and causes the obstruction. There's one very interesting studies on them, that this patient who went through this procedure, they have looked at their nasolacrimal duct, and various tests here and there, and they proved that even 6 months, a year, 2 years after, there's nothing going there. So we don't know exactly what's happening. Maybe at a microscopic level, but clinically, we don't see any change.
Thank you. Jason. So, Professor P.S. Mayer, he will present his case.
So, good afternoon, ladies and gentlemen. Now, I got two presentation, depends on the time, but it's mostly for our backbenchers, not for those top guns sitting in the front desk. 46-year-old lady, and she came to our glaucoma clinic for evaluation that her mom has glaucoma. So she would like us to tell her what's happening to her. And she has been to the 2-3 ophthalmologists in the town, and she was told that there's nothing wrong. But she feels there's something wrong with her. So we looked at her. You can see base corrected visual acuity was 6.6, right eye, and -4 diopters, left eye 6.9, again with -4 diopter and also 1.5 still. Intraocular pressure was 14 millimeters of mercury. So this was about 9 o'clock in the morning, and gonios angles were open. And you can see she had a thin corneas at 486 microns in right eye and 492 microns in the left eye. And these are her fundus pictures. And you can see what we see here. There's a 2 splinter hemorrhage on the left side. And we did the RNFL analysis, and you can see almost normal. And here we found out they were thinning in their superior-temporal quadrant. And this is her fields, which were normal. So we were not sure what's happening here, so we did a facing. You can see her pressure was 12-15 millimeters of mercury at 10 a.m., but it shot up to 26 millimeters of mercury in both eyes at 5 p.m. So this patient has definitely what we are now terming as a pre-perimetric glaucoma. And the risk factor that you would counter in this lady is raised intraocular pressure. She is more than 40 years of age. Her mom has a glaucoma. She's myopic, and she's got thin corneas. So what do you think? Who is going to start on treatment? Any offers? Correct IOP? Well, that's very interesting thing. We do not, we feel that we are not correcting the IOP because of the thin corneas, right? We don't do it. We don't do it anymore.
No,
Rush-
we don't.
rush.
No, we do not correct. This is what Yusuf said in the morning. We do not correct intraocular pressure based on central corneal thickness. That's 20 years old idea. 20, 30 years old.
So we know that the thin corneas are an independent risk factor in the pathogenesis of glaucoma, but we don't look at the table and say, okay, this is the pressure. But even if you do that, 26, so you can add upon that, means she is already running in the early 30s. तो क्या करें इसको? दवा देनी है? Who is going to treat her? Will you treat her? Okay, so she wanted to be treated because her mom has gone almost blind. So there's also psychogenic factor in the family, and apart from her mother, her two brothers also have glaucoma. So she wanted us that you have to do something. She wanted me to actually do the surgery. So I said, look, you don't need to have a surgery because of this glaucoma. We were very happy to control it medically. So we have started her on the medicine, and she regularly visits her, and she is stable. Her intraocular pressure has come down to 15 millimeters of mercury in both eyes, and otherwise, she tells me that, there was something going on in her, she headaches, but she could not describe what exactly was happening, maybe because of the raised intraocular pressure. So sometimes when we talk about primary open-angle glaucoma, we say that it's a symptomless disease. Patient doesn't have anything, but sometimes people come with very, very fancy symptoms, So we have to be very careful evaluating these symptoms and we starting this. So this is just I put for the juniors why you see the splinter hemorrhage. Classically, they were defined for the normal tension glaucoma, but now they are described also in primary open as well as primary angle closure. And it normally indicates for the glaucoma progression and requires enhancements of the glaucoma treatment. Usually precede retinal rim changes and visual field defect. And they can also be found with the retinal vein obstruction. So I got another 5 minutes, and I just want to show you another interesting case. This is a 43-year-old female complained of decreased vision in both eyes for 1 year. She was diagnosed as glaucoma, and she was using a combo of timolol 0.5% and dorzolamide 2%, and also latanoprost at nighttime in both eyes. She was referred for further glaucoma evaluation, and you can see her general health is normal, no family history of glaucoma. Vision is 6/6 both eyes, and with very small correction. Angles are open, and corneal thickness 500 microns almost in both eyes. Intraocular pressure was 13 millimeters, and throughout the day. We checked it at 9 o'clock, and then we did it also at 4 p.m. Now, this was the patient that I was talking earlier with Professor Damji, that color vision was normal, but this was checked on Ishihara. So this is the fundus photographs. Now, you can see the difference in the intensity of light. This is because of the camera. It is not related to the, but that was the, you can see. So we thought that her neuroretinal rim looked reasonably good, and we were really not convinced about that she may be having glaucoma. And this is our OCT. So she has a temporal defect on the right side and temporal defect on the left side. So I'm not sure there are residents here or not, but diagnosis is this glaucoma. What investigation you would like to do? So we did MRI, and MRI came out with what Professor Imtiaz Ali has already described, 2 cases, pituitary tumor, and then this patient was referred for the neurosurgical as well as for the endocrine opinion. So what the lesson here is that not every case where you have a blurred vision or reduced vision is because of the glaucoma. We need to go beyond this, looking at the eye only. If you're not sure, we have to do the MRI imaging. You can do the carotid Dopplers. You want to make sure why this patient is complaining about and why he has got these field effects. Thank you very much for listening.
Thank you, sir. Sir, I just have a question. When we are seeing, usually when I'm seeing also same patients, we are advising the central visual field test. But some of the ophthalmologists, they are asking regularly about what is the role of the neurological visual field test, or what is difference between the 60-2 and 24-2 in these cases? So what do you think and how do you do that? Ajay sir. Idhar se. So in neurological cases, we usually do 24-2, but some of the people, the general ophthalmologists, they're asking that why don't you do the neurological test, the 60-2 or full field test?
We do normally, I think I have felt that if you do 24-2, that picks up the hemianopic defect very easily. And you can do 30-2. Sometimes the neuro department, they refer us, they always ask for the 30-2, So we carry out and we have compared them and we don't find any change.
I think the studies seem to suggest that it's only 5% of cases would be outside that 30 degrees. So then you could do the 60 or the 120 full field and catch that with the static, or you can do octopus or Goldman kinetic testing to pick up very peripheral defects. But those are the exception. Most people will have defects within the 24 degrees, and even a CETA fast or something quick would pick it up.
So our next presenter is Professor Sadia Farooq, and she will present her case.
Thank you very much, Dr. Yusuf, and Bismillahirrahmanirrahim. After Dr. Damji's presentation on HE valve, so HE valve is generally, or tubes are the last resort in glaucoma surgery, and when we have trouble in it, usually we are left with not many options. So here I would like to describe one of my patients in which I had to face some unusual consequences after ever glaucoma valve. Before that, a brief description of whenever we decide that the tube has to be implanted, we have to make a series of decisions. Which type of implant, which size of implant, where to position the end plate, where to put the tube, how to deal with the delayed pressure control, and what measures can be taken to minimize the risk of complications. Because obviously this is a last resort, and all we want to is to ensure the best long-term outcome of the tube. Or in other words, I would like my tube to work for 10 years at least. A lot of literature is there that confirms that tubes in the anterior chamber are not doing very well with the cornea. So there is a significant corneal endothelial loss when the tube is placed in the anterior chamber as compared to when it is placed in the posterior chamber. The two main determinants are the length of the tube and the angle of the tube when it is placed in the anterior chamber. Sulcus placement of tube is a safe and effective procedure, especially in pseudophakic eyes. When posterior chamber IL is there, so it's better to put the tube in the sulcus because this is a favorable option for those patients, especially those who have a compromised cornea or the risk of endothelial decompensation. So this is what I did. I put a sulcus tube, and let's discuss the case in detail. Mine was a 56-year-old IDDM patient. She flew from UAE, and she was here for 4 weeks only for the surgery of both eyes. She was bilateral pseudophakic with uncontrolled secondary synechial angle closure glaucoma, neovascular in both eyes. She had a history of anti-glaucoma drops for a few years. Best corrected visual acuity was 6/60 in right eye and 6/24 in left eye. Intraocular pressures were 24 right eye, 26 in left eye, maximum topical anti-glaucoma medications. And she had advanced glaucoma curve disc ratio of 0.9 and had stable burnt out diabetic retinopathy. Her ocular surface was not healthy, and she had punctate epitheliopathy and conjunctival hyperemia because she was using non-preservative free anti-glaucoma drops. Surgical options were discussed with the patient because of the short time that she was here, and follow-up was not possible, and considering the condition of the ocular surface, advanced disease, Ahmed glaucoma valve was offered. Left Ahmed glaucoma valve with mitomycin 0.4 milligram per ml for 3 minutes under general anesthesia was done because she was a very apprehensive patient. And for long-term better corneal survival, tube was trimmed and adjusted in the sulcus with the edge just visible at the pupillary margin. She had pressure 20 millimeter of mercury on first visit, and the tube edge was barely visible at the edge of the pupil. So again, if we go back to the evidence, we see that a lot of evidence support the tube placement that is long enough to be visible at the edge of the pupil, and I've been doing it in my patients, many of my patients, without any problem till now. She had intense inflammation. It was out of proportion to what the surgery was done because it was an uneventful surgery. She had flares, cells +3, and she was managed by topical steroid and a short course of oral steroid. Within a week time, inflammation resolved, but her pressure rose to 28 in left eye. She had a flat bleb over the body of the valve, and the tube edge was no longer visible on the pupil, even on pupil dilatation. Then within days, her IOP rose to 32 millimeter of mercury. Because she wanted a definitive solution and there was no reason for why it has happened in this patient, we discussed re-intervention and she underwent flushing and readjustment of the tube. IOP came down to 12 millimeter after flushing and readjustment along with digital massage for 7 days. Corneal edema settled in 2 weeks and her vision even recovered because now she was no more using anti-glaucoma drops, so it improved to 6/18. And this IOP was maintained at 3 weeks of follow-up till she was with us. She underwent HE valve with MMC and implantation in right eye as well. And this time I opted for a shorter tube and then she underwent iridectomy over it with the help of cutter at the same time to avoid the entrapment of the tumor at the pupillary margin. Her IOP was, she had a straight course recovery in the right eye with IOP 12 and 14 in both eyes with no anti-glaucoma drops at 1 month from follow-up. So this is a video of the patient when she underwent intervention after the pressure rose. Because we anticipated that it's going to take some time, so we put an AC maintainer. First of all, I looked for the tube. So with the help of irrigating hydrodissection cannula, I could find the tube, but for some reasons it was not coming out into the pupillary area. So something was holding it back. And finally I realized that it was a fibrinous membrane that was wrapping the tube from all sides. And it was in fact blocking the lumen of the tube as well. It could not be freed easily with the help of this simple hydrodissection cannula. And so finally I decided that I should cut it with the help of a bimanual cutter. So I used a bimanual technique with the one and I was keeping the tube in place, and with the other, the cutter, I started cutting the tube, taking care not to cut the tube end. And as soon as the tube was starting freeing from this inflammatory membrane, it was staying in its position without my holding it. Then I freed it underway and within the pupillary area, and this membrane was extending under the surface of the iris as well. So I tried to cut it as much as possible. So this is the same cutter settings, 300 to 400 cutter and vacuum of 250 millimeter of mercury on a regular Centurion machine. So finally, when it was completely freed off, I had a fear that probably some debris has gone into the tube, so I flushed the tube with 0 cannula in the posterior chamber. Tube was staying very well in its position and its edge was visible in the pupillary margin, but I was not satisfied, so I decided I will tuck it in the iris so it doesn't go back again. So a small iridectomy was done with the help of a scissor, and then with the help of a dialer, I put it out and then tuck it in position, and finally flush it again. So after this, AC maintainer was removed and hydrodissection was done, and the patient was doing well after surgery. The second eye, when I did, I intentionally went for a different technique and trimmed the tube. I put it in the ciliary sulcus, and at the same sitting, I went for making an iridectomy with the help of a cutter overlying the tube so that I don't need the tube to reach the pupillary margin. And the patient had a short recovery in this side. This is a post-operative position of the tube. In the right eye, the tube, we can see it is visible at approximately 11 o'clock, and the pressures were controlled, and it's free from touching the iris. And in the other eye, the tube lumen is visible. And we are having an advantage of a ciliary placement, but at the same time, the chances of entrapment of tube under the iris are reduced by this technique. Although the patient was managed well, but still it has led to some questions. First of all, what has led to severe inflammation in one eye and not another one of the same patient with same surgical technique? And what should have been the preferred best clinical practice for such cases? Whether we should have done what we have done in the left eye, the right eye for the left eye as well, or otherwise? Thank you very much. So I stop here for any comments. And
thank you, Professor Sadia. Nice case. Any question? Okay.
Sorry, sir? The inflammation caused the membrane formation, yes. Yeah, YAG laser, it was too much membrane. It was entrapping it all around. Even it was not going away with a simple cannula. So we could have YAG laser. The inflammation settled, we could have YAG laser. But we have flushed the tube. Still on the first day, patient had high pressure. Then I did digital massage. So then finally it was cleared. So I think definitive solution would have been to clear it all rather than just doing YAG laser. YAG laser is usually done for when there is a vitreous wick in the tube. Then a very small wick is there and it lies with laser. But it was a web of membrane, a whole net of it.
Thank you so much, Dr. Sadia. Very nice presentation. Just two quick questions. Do you think it has anything to do with priming the AGV? Do you think you primed as you usually do? And secondly, the placement that you did through the iridectomy, don't you think that angulates it toward the endothelium rather than downward, that what you usually aim for?
Yeah, the same I think, because if we see literature, then people, they keep the ends of the AG valve under the surface of iris. They don't let it come even at the pupil. So why don't their tubes shove the undersurface of iris and cause pigmentation? But I believe maybe our patients have a thick pigmented posterior pigment layer, and that's why probably the angle was not well, and but it happened very early. If we expect that the tube has shoved against the posterior surface of iris, it would have taken longer, but in this case, it has happened immediately. I think it was some toxic reaction to the material of the tube. This I was thinking about, because she had an out of proportion reaction. Usually we do not see AG valve with such heavy fibrin and hypopion. Even she had a 1 millimeter hypopion as well that disappeared on treatment. And it was not infection, it simply resolved with just steroids within days. So, what about the, does everyone agree on the ciliary placement of the tube as we have done in the right eye? Because I think that was simpler and easier solution for the patient, and we do not have a long tube there. And
Yeah,
chances
but
of
why didn't you leave it long? Why you left it short, and so you struggled to find it. Why didn't you leave the tube long in the first case?
in the first case, because I'm implanting it like this, I never had trouble, so that's why I do it in my routine way. But because the patient had problem in one eye, so I don't want it.
Okay, so my first tube that I did in the sulcus, I left it short and it kinked. And the pressure is 47, and then I had to go, and when I took the tube out, it completely kinked. So two major complications of sulcus placement are kinking and the bleed.
Yeah.
So we don't know whether when you push the tube in the sulcus, you cause some level of bleed. The other thing I've learned from experience is when I put a tube in the sulcus, and I'm not sure whether it will go in the sulcus, I go from 6 o'clock and then I put a gonio prism and then go in the opposite direction to make that tunnel, because you're not sure, if you go from outside, what you're going to do. It is blind procedure, the tunnel formation. So I go from the 6 o'clock. I think it could have helped. And the other case where you make a small iridotomy, I'm not convinced, because then you also cause some glare and the quality of vision. She's a young woman, right? You never know, she can come and, oh my God, now I've got glare. And so what do you think you gained by making that iridotomy in the second
Iridectomy. So basically, I've seen a pediatric surgeon, Dr. Sang Vilota. I've worked with him for some time. Yeah, he do it in the same way for pediatric patient, and his valve
Birmingham.
At Birmingham, yeah. So he Sang Vilota is a routine way of doing pediatric VG valve. So he just put it in a ciliary sulcus in a pediatric patient.
Okay.
Because why I didn't do it in the first, we have a private setup. Our patient is charged for a cutter and a separate set. So that's why I didn't go for anterior vitrectomy in first case. But I think it's worthwhile. So a shorter tube and the posterior placement.
I think the first eye, there's something funny going on. So it could be a sterile inflammation similar to TAS. And maybe there's some other factor causing that, because just a tube by itself rubbing in the back of the iris doesn't usually cause a hypopion and the type of inflammation that you're describing.
I agree. Yeah, absolutely. Thank you very much, everyone.
Thank you.
So, Sadia? Sadia, Professor Meher has raised a very important point that, and it was published last month in Journal for Glaucoma, that if you wash anterior chamber you already had a AC maintainer, so you're constantly washing.
Yeah.
But if you do not have an AC maintainer, both in trabs and in tubes, if you wash AC maintainer, so what happens is that you wash this inflammatory aqueous. And once this inflammatory aqueous is completely removed, then the bleb fibrosis is reduced. So
Yeah.
these patients, they actually perform a lot better. So that's the sense and sensibility behind washing the anterior chamber in tubes. But the importance, what I noticed was, you can place the tube in the sulcus, that's brilliant. But if you're placing it in the anterior chamber, AGB tube is too thick. When you pass it through, like Aisha said, we actually pass it with visualization through the gonial lens, because we want to pass it through the trabecular meshwork. It's not the length of the tube that affects the endothelium. It is the position of the tube which affects the endothelium. If it's above the trabecular meshwork near the Shoulders line, it will continuously cause endothelial dropout.
Yes, there is a way of suture-guided placement of tube as well. Like through 6 o'clock, we pass the suture and then take it out and then pass through. Then the tube just slides over that suture and goes exactly at the same angle. I think it should be even safer.
It's a good idea to visualize it from where you're going to pass it.
Thank you very much.
Thank you, everyone. So, Professor Mahmood Ali, is he here? Yes, I'll ask him to present his case.
Glaucoma is a multifactorial disorder, and sometimes missing simple things can make the management complex. And likewise, doing simple maneuvers or doing simple things can make the management easy. So this is a case that I am going to present. 28-year-old young lady presented to my clinic. She is a staff nurse working at a government hospital, resident of Rawalpindi, where I work at Al Shifa Trust Eye Hospital. Presenting complaint was decreased vision in both eyes, especially for the last 6 months. History of present illness: the patient had bilateral progressive painless decrease in vision for the last 5 years and was diagnosed as a case of juvenile open-angle glaucoma. Vision loss was more noticeable in the last 6 months, and it was not associated with any pain, flashes, floaters, etc., or other symptoms. There was no history of ocular surgery or laser or trauma previously. Regarding past medical and surgical history, the patient was already using 3 bottles of anti-glaucoma medication. She had a history of systemic hypotension, and she was a staff nurse. Sometimes she was not very keen in taking diet regularly. When during daytime she skipped the lunch also, so, and she was not taking it seriously. So case of a systemic hypotension, and there was no history of steroids. So she belongs to a middle socioeconomic status and is married. So on examination, well-oriented person in time, place, and person. Vital signs: her pulse was 56 per minute, blood pressure 90/45. She had a history of hypotension, and I confirmed it in my office, and it was 90/45 millimeters of mercury. Respiratory rate and temperature were normal. Pallor was absent, cyanosis was absent. On ocular examination, she had a visual acuity of 6/6 in right eye and 6/18 in left eye. Intraocular pressure was 17 and 18 with 3 medicines, as I have already mentioned. And gonioscopy revealed open angles in all quadrants with iris processes. Cup disc ratio was 0.7 and 0.9. Pachymetry was 0.552 and 0.526. So OCT RNFL scan, previously she had a bulky file with her, and 3 multiple OCT scans were done, but the last 3 consecutive OCT scans were done on the same machine, and they were showing progression very rapidly. she was reluctant to undergo any surgery because she was a staff nurse, and one eye had a vision of 618, but that had a tunnel vision. And she was only dependent on her right eye, and she was unwilling to undergo any surgery. So I offered SLT, selective laser trabeculoplasty. Since she was hypotensive, so I referred the case to the medical specialist for anything that we can do. Systemic investigations were also conducted, and after that, SLT was performed, and I also revised the medical treatment and omitted beta blockers after the SLT. After 1 month, the heart rate improved to 62 per minute. Previously, it was 56 per minute. And a patient was encouraged to take light snacks during the duty hours. And her blood pressure also improved by 10 millimeters of mercury, both systolic and diastolic. And she also noticed this thing that her vision is stabilized. But I asked her to get the OCT repeated at least after 3 months so that we can actually see what is happening. This is the initial OCT of right eye and left eye, and it is the global values are 56 in right eye and 31 in left eye. So we can see almost complete thinning of RNFL on left side, while in the right side we can see two quadrants. One quadrant is green, one pi quadrant or sub-quadrant is green, rest all is red and yellow. This is the initial scan in February. Now, just look what is happening. This was the scan in the February. Since the patient was very, in a panic and was regularly getting her OCTs done. So just after 2 months, usually I don't advise OCTs before 6 months, but the patient herself went to the OCT hospital and got the OCT done regularly at 2 months interval. So this is the OCT. You can see the global value 56, one quadrant yellow, red, and these are two. Now, just after 2 months in April, the global value dropped to 54. One more quadrant that was previously green turned to yellow. And in August again, 3 quadrants yellow and red. This was before SLT and coming to my clinic. So as I mentioned, I omitted beta blockers, encouraged her to take light snacks so that the blood pressure can be improved. SLT was done in a hope that the number of medications could be reduced. And now, this is the last OCT, and you can see there was improvement. All the yellow quadrants, they have turned to green in just 3 months. And you can see this is the initial, from the 28th February to 29th April, what happened. You can see this graph, overlapped graph between these two readings, and you can see these areas, there was a progression. This one and this area, these areas show progression. Then from 29th April to 3rd August, you can see further progression occurring. The RNFL is dropping here, and after SLT and all that medical management, see now previously it was dropping down. This is in red color. And now in the latest OCT, it is green. It is turning, yellow areas are turning to green. These are all OCTs, and this is the latest one. This is the OCT of the left eye, which is stable at 31, global value. Visual field, these were the visual fields in the April, and these are the latest visual field. You can also see some improvement here. I also performed some investigation. Folic acid and B12 levels were normal, because I noticed a patient had low folic acid levels, and with treatment, improvement in folic acid level, his visual fields improved. So I just ensured that whether there is any problem with B12 level or folic acid, but they were normal. So coming to the discussion of this case highlights the importance of going beyond eye to focus on the whole patient. A low perfusion risk is a risk factor identified in many landmark trials, and there is little ambiguity that lowering the IOP can improve the perfusion. So the mean ocular perfusion pressure was less than 30 in this case, but after the management, you can see the intraocular MOPP or mean ocular perfusion pressure that improved to more than 30 millimeters. And studies have shown that mean ocular perfusion pressure, if it is less than 50, there is increased risk of progression of glaucoma, and especially if it is less than 30, the risk increases to 3 to 6 times. So SLT, how it helped? SLT, we know it is a double frequency Q-switch ND-YAG laser, and its spot size is 400 microns, duration is 3 nanoseconds of the pulse. And it is, in order to understand its mechanism of action, it is important to understand the thermal relaxation time. The time of the pulse of SLT is much less as compared to the thermal relaxation time of melanin in the trabecular meshwork. So the energy that is generated from the SLT pulse is very slowly released. As a result, there is no damage or mechanical damage. So it is a cool laser usually, if not done very aggressively. SLT and ALT, argon laser trabeculoplasty, IOP lowering effect is the same, but the mechanism of SLT is slightly different from ALT, and these include the biological changes, repopulation of trabecular cells, and remodeling of the extracellular spaces. And the success rate of SLT is 70% at 1 year and 50% at 2 years. So with this, I come to the end of my presentation, again highlighting the importance of holistic approach while managing the cases of glaucoma. Thank you very much.
Okay, thank you, sir. So I think we are just late of the time, and the next plenary session, they are waiting for us. All the speakers are requested to kindly collect their shields and certificates from the Saver Hall. Thank you, everyone.